Hello, everyone. Thank you for joining this briefing. I'm Ali Rogers from Global Health Strategies, and I support communications for the Global Polio Eradication Initiative. I'd like to welcome you all to the briefing to mark the program's 35-year anniversary. Our discussion today will focus on the incredible progress that has been made, the challenges in the last mile, and the GPEI strategy for 2023 and beyond to finally deliver a polio-free world. We're grateful for your participation today and your continued interest in closely following eradication efforts. Before I begin, for any French speakers on the line, to activate simultaneous interpretation, please press Interpretation, the globe icon at the bottom of your screen, and tap French. You can then click on Mute Original Audio to cut original audio if necessary. To disable the interpretation at any time, press Original Audio Interpretation Off. My colleague will say all of that in French in the chat. This briefing will include 25 minutes of presentation, followed by 30 minutes of open Q&A. Our speakers are Aidan O'Leary, Director of Polio Eradication at the World Health Organization, Hamid Jafari, Director of Polio Eradication at the Eastern Mediterranean Regional Office of the World Health Organization, Felicite Chibinda, Deputy Regional Director of the West and Central Africa Office at UNICEF, and finally, Myra James, a polio survivor and One Last Push advocate. This briefing is being recorded. During the speakers' presentations, all attendees will be in listen-only mode. If you would like to ask a question during the open Q&A portion of the event, please press the raise hand function at the bottom of your screen at any point during the call, and you'll be added to the queue. You can also write your question in the Q&A box at the bottom of your screen if you'd prefer. If you have dialed in by phone, please press *9 to raise your hand. Please state your name, organization, and who you'd like to direct your question to, whether you write it or say it verbally. Following the presentations, I will read your question or will call on you to ask your question, and you will see a pop-up enabling you to unmute and start speaking. To withdraw your question at any time, please press the lower hand function at the bottom of your screen. I would now like to turn the call over to Aidan O'Leary from WHO to get us started.
So thank you very much, Ali, and a very good morning, good afternoon, and good evening to everybody who's joining the webinar to reflect on the progress that GPEI has made over the last 35 years and the challenges that we're working to confront in the weeks, months, and quarters ahead. I'd also like to take this opportunity at the very start of the session to thank all of you who have joined for all that you do for polio eradication, and particularly the work that's undertaken to really make sure that we maintain the necessary will and the urgency to make sure that polio is eradicated and transmission stopped anywhere that it exists. So to go very briefly back to the start, the Global Polio Eradication Initiative was formed at the World Health Assembly in 1988, where essentially 166 member states decided that we would take on the collective undertaking of eradicating polio worldwide. The intent was essentially to build on the significant work that had been done and join our smallpox as the what would be only the second human communicable disease ever eradicated. Not a small ambition, a big ambition, and one that we remain very firmly committed to. The GPEI is a public-private partnership that brings together all member states across the world, together with 6 core partners, namely Rotary International, the United States Center for Disease Control, UNICEF, Gavi, the Bill and Melinda Gates Foundation, and the World Health Organization. And we remain very much committed towards delivering on our goals. As we're all aware, Rotary International, through its Polio Plus program, was the original visionary of a polio-free world. and we remain indebted to the partnership that Rotarians all over the world continue to bring to the program to this day. If we reflect on the progress that has been made over the last 35 years, I think it's important to recognize where we started. In 1988, we had a situation where essentially 1,000 cases a day were being reported across 125 countries. So when we look at the situation in which we face ourselves now, the numbers as our Rotarians would say, we are 99.9% of the way. However, we need to really finish the job. What we have seen is, while we are focused on achieving and sustaining zero as the goal, we cannot reflect or ignore the fact that to date, more than 20 million people are kind of walking today as a result of the enormous efforts by member states, frontline workers, communities, and the partners to ensure that paralysis is absolutely minimized. When we look at the work of the Global Certification Commission, what we see is a situation where in September 2015, wild poliovirus type 2 was certified as eradicated. In October 2019, poliovirus type 3 was certified as eradicated. We have a single wild poliovirus type 1, which remains on the books. As we stand today, Afghanistan and Pakistan are the two remaining wild poliovirus 1 endemic countries on the way to finishing the job of eradication. So I think that brings us then to the current epidemiology and the remaining challenges that are ahead of the program. So I think that the first point to note is the goal that has been set out in the 2022-2026 strategy, which is to interrupt all the remaining transmission chains by the end of this year. We have basically in Afghanistan and Pakistan reduced the endemic zones to the very bare minimum, with just 2 provinces in eastern Afghanistan and 7 districts in southern Khyber Pakhtunkhwa in Pakistan itself. Hamid, in his remarks, will kind of elaborate on the detail in terms of the snapshot for the endemic countries. I think I will focus more on the situation with the variant polioviruses that the program is dealing with. And as it stands, there are a number of small but very consequential geographies that lie between the program and achieving our historic goal. These are northern Nigeria, Eastern Democratic Republic of Congo, the South Central Somalia, and the northern Yemen. To this list, we had also added northern Mozambique in response to the WPV1 importation during the course of 2022. I think what is really important to note around these locations, firstly, is we're not speaking of entire countries. We're speaking about very small, concrete subnational geographies. But these geographies represent the highest concentrations of zero-dose children. These are the unimmunized or under-immunized, underserved children who have not been protected through vaccination. They are the top priority for the program. Each of these areas are subject to a range of what humanitarians describe as protracted complex emergencies. They're subject to challenges of insecurity, inaccessibility, and a very wide range of humanitarian needs that a range of programs continue to work to try and address. The situation in each of these countries has been further exacerbated by the 2020-21 pandemic, where what were already low immunization coverage in these particular areas was even further reduced. And a major part of what the program is seeking to do is to work with other immunization partners, work with other humanitarian partners to really make sure that we bring not just polio drops, but a range of other antigens and essential humanitarian services to meet the needs of these communities in most acute need. This remains an ongoing work in progress, where we have made different strides, different paces in each of these geographies of concern. I would also like to emphasize what the key challenges of the program are in terms of strengthening surveillance and strengthening immunization in these areas. This is not a question of vaccine types. This is a question of gaining access, building community acceptance, confidence, and trust, and then really making sure that we deliver high-quality campaigns to maximize coverage in each of these areas. What we have seen is steady progress across each of these geographies, which we are going to have to continue to intensify and build upon over the course of the remainder of 2023 into 2024. But based on the progress that we have seen to date, I think we are well set towards delivering on these key goals. So maybe with that introduction, if I can pass to my colleague Hamid Jafari, who will take us through the endemic snapshots.
Thank you, Aidan, very much for that nice overview. So, friends and colleagues, we are seeing a level of progress in Pakistan and Afghanistan towards polio eradication that is unprecedented. We have never seen this level of progress. Both of these countries have seen periods of low incidence of cases, followed by periods of resurgence of outbreaks. But this time it looks very, very different. As Aidan mentioned, that we are seeing extreme geographic restriction of transmission. 7 out of 180 districts in Pakistan, 2 out of around 36 provinces of Afghanistan is where we are seeing transmission persist. We are also seeing long intervals between incidents of cases. And then a very important marker of progress is the reduction in the genetic diversity of polio viruses. That means when you have a lot of polio virus around, there are many families and they are dividing into and subdividing into many families. Right now, there is one family surviving on the Pakistan side and another family surviving on the Afghanistan side. So it's really hanging by a very, very thin thread. And this picture is quite consistent with what we've seen in many countries towards the end stages of eradication, whether it was India and Nigeria, where actually in the final stages, you see that the historic endemic reservoirs that sustain and drive polio transmission get cleaned out. And that's what we are seeing in Pakistan and Afghanistan, that most of the traditional historic endemic reservoirs are actually without transmission for nearly, or in fact, in some instances, more than 2 years. And whenever virus has even spilled out of these focused areas of transmission and has been detected in environmental surveillance, they have responded very vigorously, these programs, and there is no evidence of re-establishment of transmission in areas outside of southern KP. So, and this is happening at a time when we are progressively intensifying and expanding surveillance for polio virus, both our surveillance through acute flaccid paralysis case investigations, reporting and investigation, as well as extensive, right now Afghanistan and Pakistan have the most extensive network of what we call environmental sampling sites. These are sewage and surface water sampling sites that detect poliovirus excretion in an infected community. So we are looking harder and harder for poliovirus, and we are finding less and less of wild polio virus type 1 in both countries. Yet the challenges in these areas where infection is persisting are quite significant. On the Pakistan side, this is an extremely complex social and political and security environment, very weak health system, very low routine immunization system. On the Afghanistan side, again, this is a part of Afghanistan where for the preceding 2 years, there was significant disruption of the program. We had, unfortunately, attack on our health workers that suspended vaccination for many months. And when it resumed, it was not house-to-house vaccination. And then when it resumed, government had changed. So it took some time to build the kind of quality of vaccination that we are seeing there now. But the progress is continuing. And I think what is very important is that at this stage of the program, it is not only about going to these communities that are very deprived communities, living in very, very difficult and challenging and insecure environments, to just repeatedly keep going back with the polio vaccine. So the polio program is actually integrating at many levels and providing broader support. And I think probably the best way to describe this would be in 3 categories. The first category is very close integration with the essential childhood immunization program. So working very closely with the routine EPI program, monitoring the performance of the program, highlighting the gaps, helping with micro-planning and monitoring. And whenever there are campaigns for other vaccine preventable diseases, there is joint planning and a lot of support from the large polio infrastructure that's very experienced in planning and implementing campaigns. So whether these are measles campaigns or whether it was COVID vaccination, a lot of support from the polio program on both sides of the border, both in Afghanistan and in Pakistan. So that's the area of immunization. The other area is integration with broader health services. So for example, in Afghanistan, the program is increasingly working with all the major humanitarian actors who are providing support for emergency health services. So closely coordinating with them and ensuring that there are polio vaccination and routine immunization services that are coupled with their other community and family health services. And I think the third area where the program plays a very important role is actually a frontline workforce to deal with emergencies. And the most recent examples of those are, of course, the role of the polio personnel and experiences in the COVID pandemic. More recently, the massive flooding in Pakistan, where the polio staff played an important role in managing the situation of the floods and supporting broader health and humanitarian assistance there. The earthquake in the southeast region of Afghanistan last year. So really serving as the first responders because their experience of providing and the ability to plan and implement activities at the community level. So I will stop here, and I'm going to invite Felicity to please make your comments. Over to you, Felicity.
Thank you, Dr. Hamid, and thank you for giving me the floor. I wanted really to emphasize the fact that we have made progress, but the progress is fragile. Fragile because no one is safe from polio as long as the virus exists somewhere in the world. In our region, we face variant polio virus outbreak that are driven by many and by several factors. Some of them were, when we talk about Eastern DRC or Northern Nigeria, the security issue, but also the acceptance of the vaccination, the whole issue around the crisis and the humanitarian, but we look also at the quality of the outbreak response campaign and some of the regional migration patterns that make people move from one area to another. One of the innovations that we see here that is helping really to address the issue is the use of the novel oral polio vaccine. And that is really helping to stop outbreaks of variant poliovirus. We know, for instance, as of May 2023, approximately 600 million doses of the novel vaccines have been administered in 28 countries globally. And 95 of the vaccine used to this has been in African countries. So that is really important to understand that that novel vaccine is safe and effective. The second innovation has already been alluded by Dr. Hamid is really looking at what we call Polio Plus initiative in Western Central Africa region by using the polio resources to really integrate child health interventions such as vitamin A supplementation, deworming, and birth registration, which is more in the child protection. And for instance, in 2022, Guinea-Bissau, Cameroon, Central African Republic, and Chad has delivered this integrated package. We also additionally use that polio campaign to strengthen the community engagement, which is really important to increase the acceptance of the vaccine and make sure that people are coming to the services. So and then strengthening the quality of the vaccines. We believe that by putting the resources together, we will be able really to have this last mile, because as we said, very few countries, small pockets in countries, and those countries need really, in those pockets, we need to go that extra mile so that we will be, the world will be free of polio. What do? We also have to look at the supply side and make sure that we have an adequate supply of oral polio vaccines, which is really important in order to respond to the outbreak. There is also, to you who are listening to us, we need to partner with global, regional, and national influencer and champion like many of you today to advocate at all levels for the prioritization of childhood vaccination. And that is really important, using those innovative tactics during high quality vaccination to really reach children across. That's an important. So it's really a global partnership using innovative approach, using also what is already existing and putting things together. That is really what we need to do to really celebrate, I hope in a few years, the end of the polio across the world. Thank you. I'm giving the floor to the next.
Hello, I'm Myra.
Mira, over to you.
Hello, yes, sorry. Yes, first of all, thank you very much for inviting me to take part in this webinar on behalf of One Last Push. And thank you to the previous speakers, very fascinating insights into the progress that's been made. I am a polio survivor. I contracted polio at the age of only 11 months in 1953 when I was born and brought up in Coventry. That's in the English Midlands. My left leg was paralysed, and I spent, I think it was about 7 weeks in an isolation hospital where even my parents could only look at me through a window. So that was a very difficult time, obviously. But fortunately for me, the next year I was able to have surgery which was carried out by a person who became a hero in our household, Mr. Jocelyn Penrose. And because of the surgery he gave me, I've been able to walk almost normally all of my life. I have a left leg that's a little shorter than the right, and a left foot that has really nothing like normal movement in it, and that has got worse as I've aged. Obviously, something like this must have had a tremendous impact on my family. I can't, as a mother and grandmother now, I can't imagine what it must be like to have such a sick child, and potentially disabled, you know, somebody affected by something so disabling. But I was fortunate. Some people had to spend time in an iron lung, or had much worse disabilities which persist throughout life. So I became involved in One Last Push in 2017 at an event in Coventry, which I went along to. I met other local polio survivors, which was very interesting. And during that time, I happened to mention that as well as being able to walk almost normally, I also learned to tap dance. I went to dancing classes throughout childhood and carried on doing it as an adult, which seemed to attract quite a lot of attention. So I was filmed tap dancing. And since then, since that time, I've been involved in One Last Push, helping whenever I can to be involved in the work it's doing to keep this subject at the forefront of everybody's mind, especially those people holding the purse strings, because it is very reassuring to hear the tremendous commitment that we've been hearing from the other speakers to continue this work to eradicate such a horrible disease, and a disease that really no one needs to suffer from anymore. I think it's tremendous work that's going on, and it just needs to be kept right at the forefront, I think, because it could be so easy to slip back, I think, if there wasn't this level of commitment. So I just want to say thank you to everybody who's keeping up this work, and let's hope we can, you know, with One Last Push, see an end to this horrible disease. Thank you very much.
Thank you to all of our speakers. At this time, we'll conduct the question and answer portion of the event. And for this session, Ananda Bandyopadhyay, Deputy Director of Polio Technology, Research and Analytics at the Bill and Melinda Gates Foundation, has joined the call with us. He played an integral role in the development of the novel oral polio vaccine, NOPV2, which we've just heard about from our speakers. Welcome, Ananda, and thank you for joining us. As a reminder, if you would like to ask a question, please write your question in the Q&A box or press the raise hand function at the bottom of your screen, and you'll be added to the queue. If you have dialed in by phone, you can press *9 to raise your hand. Please state your name, organization, and who you'd like to direct your question to. I will then read your question or call on you in the order it was received, and you will see a pop-up enabling you to unmute and start speaking. To withdraw your question at any time, please press the lower hand function at the bottom of your screen. We're now ready to begin, and I'll start with some questions that were put into the chat box. Our first question is from Obina Eberim. Can the speakers touch on how advocates like myself on the webinar can best communicate cases of CVD-PV1 and 2 in Nigeria and DRC while raising awareness to avoid misinformation due to the term vaccine derived and killing the joy that Africa is free of polio? I'll start by passing this to Felicite and then maybe on to Aidan for your thoughts as well. Felicite, go ahead.
I think that's I think that's what is important in terms of communication is really using simple words that will resonate in the head of the people. When you use too technical words like CV, the people will not hear. So I think that using the word variant will help people to understand that we are talking about, in Africa, there is eradication of the wild poliovirus, but we still have some variant form. We have seen that with COVID, we have variant form that we need to deal with, and we are almost there, because basically 2 countries that are having the great majority of those is DRC and Nigeria. Over.
So our thanks, Ali, and also our thanks for the question. I think simply building on what Felicite has mentioned, I think is the kind of almost the counterintuitive piece is that actually the risk arises from the lack of vaccination and the lack of protection. And if we look at the 2 countries in question, you know, Nigeria are accounted for 2/3 of the variant caseload globally in 2021. And since that time has been engaging at scale. More than 350 million children have been vaccinated over the course of the last 18 months, with the number of cases being recorded reducing down to a handful. And what we're essentially left is with challenges in Sokoto and Zamfara, where the issue is insufficient levels of vaccination, where we have to basically ensure that we find the right ways to reach the populations that are underprotected. We see a similar dynamic in DRC. The problem isn't countrywide. The problem is in those provinces, mainly in the eastern part of DRC, where we have extremely low rates of immunization overall. So while DRC may be recording immunization rates of 65% plus, in the east, it's in the 20 to 30% range. And unfortunately, it's those children who are not being vaccinated, who are not being protected, who are basically those who are being infected by the virus. And the challenge for the program is to really make sure that these children are not at the back of the queue, they're at the front of the queue when it comes to vaccination. And I think the prioritization that's underway is really geared towards making sure that places like Manyema, Tanganyika, and Hautla-Momi are really boosted and bolstered in terms of coverage to make sure that those necessary levels of protection are provided. Thank you.
Thank you both for that answer. Again, a question that was written in the chat from Muhammad Hakim. During the pandemic, if immunization coverage was low, then why were the polio cases, why were there so few? I'll pass this back to Aidan.
So I'll kick off on this, and maybe Hamid would like to complement. I think unfortunately during the pandemic, the polio cases were not few, and I think what we saw both for Afghanistan and Pakistan in terms of wild polio, and what we saw particularly in relation to the variant or the polio variants, was that we saw actually a tripling of the caseloads between 2019 and 2020. And it's essentially what had happened was that more than 60 campaigns had been postponed across 28 countries. And what that essentially allowed was time and space for the virus to circulate. And what we've been working on since then is essentially working to close those gaps in relation to immunization coverage to really make sure that all children are vaccinated and protected. So unfortunately, the pandemic wasn't actually a contributor towards lower cases per se. It actually resulted in the, as I say, or increasing by multiple factors in 2020, and we've been working to address that. Where the pandemic has helped, I think, is in the areas around restricted mobility and better hygiene practices. And there's no doubt that as we progressed through 2020 into 2021, we do see some of the benefits that were beginning to flow from that to complement what were also the restarting of campaigns by our ministries of health, millions of frontline workers who went back into action to really make sure that kind of children were basically protected and vaccinated. So I think the simple answer is that unfortunately the pandemic didn't contribute to a reduction of cases, quite the reverse. But in terms of that, our side benefit of reduced mobility and better hygiene practices, that was certainly an assistance to the program overall. I'm not sure, Hamid, would you like to compliment?
Yes, just to add, no, that's correct. And just to add that the polio program was very resilient, that we had in Pakistan and Afghanistan, after an interruption of campaigns for 4 months, the programs in both countries very rapidly adjusted their operations to the pandemic, including assessing the threat to the vaccinators as well as the communities that they were serving, provided personal protective equipment to the vaccinators, modified their training, excluded people who had any symptoms from the workforce, and were very quickly able to restart vaccination campaigns, actually in the midst of outbreaks of both wild polio virus and vaccine-derived polio virus in both Afghanistan and Pakistan. So I think that gap was a setback, but I think a quick restart and then intensified campaigns really helped to control the outbreaks, and clearly the factors that Aidan mentioned also helped. Back to you, Ellie.
Great, thank you both. Going to another question in the chat from Xavier Saz Yoren. Can you explain the very few cases of CBD-PV due to the neurovirulence recovery of NOPV2, the novel attenuated virus, after recombination with some environmental enteroviruses? I'll pass this over to Ananda.
Thanks, Ali. Good to be here with all of you. Javier, I must note, has actually led the early clinical development of this vaccine from Panama. So thanks to his team. So this is an important question. NOPV2, or novel oral polio vaccine type 2, is a more genetically stable version of the Sabin OPV2. So it has less likelihood to revert to neurovirulence or lower risk of generating circulating VDPVs. And we have been saying this, that we have essentially fixed the loose ends of the Sabin OPV to generate the novel OPV. However, the novel OPV is still a live attenuated vaccine virus. So although there is lower risk of reversion to neurovirulence, it's still not really a no-risk vaccine. And again, the same sort of risks that are there with the Sabin OPV2 in specific settings of persistently poor vaccination coverage, high enterovirus prevalence, they also are there for NOPV2 reversion risk, but with that strong caveat that the overall risk with NOPV2 is still much, much lower. If you look into the numbers that we talked about already, we have used 600 million doses of NOPV2 in 28 countries. And in most instances, we have really not picked up problematic reversions. The two reversions that we have picked up that have generated circulating vaccine-derived polioviruses derived from NOPV2 use is consistent with our knowledge of the pathway to recombination that does exist even with NOPV2. So there is a double recombination mechanism where the cis replicating element, or CRE, that is there in the genomic structure of the vaccine, if it is swapped with a recombination event with another human enterovirus C, that opens up the possibility of another recombination within the vaccine virus. So it's kind of a series of double recombination that can introduce this risk with NOPV2. But please note again that with Sabin OPV2, even a single recombination can lead to such emergent variants, or it can also go through spontaneous reversion in certain instances. With NOPV2, we are protected from that perspective. It's still 2 steps away from such problematic reversions. And the fact that out of the 600 million doses in 28 countries, thousands of samples processed through whole genome sequencing, the fact that it's only 2, although unfortunate, it's actually reassuring that the scientific principles that were followed, the understanding that we had as to how recombination might happen in such a virus, it's actually holding true. And it points out to good surveillance, even in places like Eastern DRC, where this emergence has been picked up. Over to you, Ali.
Thanks so much, Ananda. Going over to Oyewale Tamori, I will now allow you to speak. You can unmute yourself.
Thank you very much. It's so reassuring to see colleagues, Hamid, Aidan, and Felicity, and others. Myra, you're not the only one. In my father's family forest, we also had people who had, we don't have a family tree, we had a family forest. And we had somebody who had 2 or 3 of our people actually got polio. They were paralyzed by polio. Although they didn't do any tap dancing, but they also danced to the Nigerian music also. So that was a good thing about that. And I think for what message I think we need to keep telling people, so much progress has been made and we cannot afford to fail. Having said that, the situation in Nigeria is, the message is, as Felicity has raised, we need to continue to vaccinate our people. And other countries have overcome such things by good, high-level vaccination. That message must go to all African countries, DR Congo, Burundi, all those other places, Nigeria, the other part, and that we must continue to vaccinate our children, and we will overcome this issue. So again, congratulations to all of you for all the work you have done. I'm happy to be a part of you. Thank you very much.
Go ahead, Hamid. You have your hand.
No, first I want to recognize Wale for the father of polio eradication in Nigeria and many other African countries. So I want to appreciate and recognize his leadership. And thanks for joining, Wale. And I think the point I wanted to make is what, building on what Wale has said in the earlier question, we are very, very close all across the world. We have the experience, knowledge, and the tools to get this done. What we need is all hands on deck. And each one of you in your capacity, certainly as an influencer, can do a lot to get communities on board, to get decision makers on board, get donors on board. Now is the time to, we are so close. This is the time to strike hard. So it's not just about one part of the, Africa. It's just where we are right now. The 2 endemic countries, Nigeria, DRC, everywhere. We can get there, but we need everybody's support. Thank you.
Thank you, Hamid and Dr. Tamori, for your remarks. Going back to a question in the chat from Charles Agbeko. If an entire community is non-compliant for years, which spells a difficult situation for the vaccination teams, do we leave them unvaccinated? And if we have to ensure they are vaccinated, how can we overcome this challenge? I'll pass this to Felicity.
Thank you so much for the question. I think that, as I said before, no one is safe from polio as long as the virus exists somewhere in the world. So we do need to understand why the community is refusing to be vaccinated, and it can be for various reasons. So that needs to be unpacked. Is why we in the package of the polio eradication, we have a strong component on social and behavior change, which is like looking at the community engagement and trying to understand and using the community to be able to address the issue. Sometimes it's just an issue that they want more information, They may not know where to go. They may have other belief. You need really to debunk the belief and work. And we have seen that in countries like Nigeria. I mean, if we are here and when we look back, there was a lot of rumors about, vaccine are not safe, vaccine is creating so many things, and through the community engagement, the social and behavior change, we're able to address that. So for me, it's really important to go to the community and understand we cannot live, as all working in the global community, it's important not to leave someone aside. So that for me. Second, I think there's a lot about, people are not accepting a vaccine. But when we did a study for COVID, we found that it was some other reason, not always that they don't want to accept a vaccine. And for the influencer, it's really important. We know the role of the social media. And we've seen that a lot of rumors, a lot of things are going rampant in the social media. It's important to give the right information at the people, and sometimes in the language they understand. It's why we use the community-based organization, the people who are at the community level, who understand the culture and the community to make it happen. Over.
Thanks so much, Felicite. A question from Nadima Farima from Aga Khan University. My question is to all panelists. What are your thoughts about the sustainability of polio eradication in Pakistan once the goal of eradication is achieved? Do you think Pakistan will be able to sustain the program in the absence of global assistance? I'll first give this to Hamid.
No, certainly. I think this requires obviously advanced planning, deliberate planning. It doesn't happen on its own, but we have good examples in our region recently. More distantly, over a period of 10 years, what has happened in India, whereby the polio eradication infrastructure was transformed into a broader public health infrastructure, particularly supporting immunization, surveillance for vaccine preventable diseases, and became very active in the COVID response. And now it's dealing with broader public health programs. So I think similarly with advanced planning and increasing funding by the government into disease control programs, international financiers of other disease programs, there are so many transferable skills in the polio eradication workforce, their experience, that with good planning and good engagement from the government first and foremost, and government's leadership and engagement of donors and partners, there is absolutely no reason why polio eradication can't be sustained. Back to you, Ellie.
Thank you so much, Hamid. Another question.
We are starting to hear the French interpretation. Maybe it's gone now.
Oh. Okay, great, thank you. Another question from Muhammad Hakim. The fake vaccination and community vaccine hesitancy is a phenomenon that exists in Pakistan and Afghanistan. What are the strategies adopted for this, and what strategies can we claim are exhausted, and what are innovative? What innovation can be done for fake vaccination in Pakistan? Again, back to you, Hamid.
Yeah, I think first of all, we need to understand that what are the antecedents and determinants of fake vaccination. Clearly, there is a trust deficit between the vaccinator and the program, between the program and the families and communities that are under some pressure to express that they are accepting the vaccine while not really taking the vaccine and just wanting a finger mark. So this actually does send very strong signals to the program that we have a lot of work to do in building, first of all, the confidence and resilience of our frontline workers, so that, and for them to be able to freely report those families and communities that are actually refusing vaccination. And then, of course, we have to partner with these communities that feel under so much pressure that they have to actually fake that their children are getting vaccinated. So I think the program has done a lot of work in terms of building bridges with the communities, building confidence in the frontline workers. But I think for example, this challenge was most pronounced in the areas of the southern Khyber Pakhtunkhwa, where we have persistence of circulation of wild polio virus, whereby the operational approach and strategy was changed so that initially when the campaign starts, children are invited to temporary fixed sites where they're provided vaccination, but also additional pluses like, soap is distributed. So there are pull factors that are included, and that brings out a lot of communities and children. And so children are then vaccinated under direct observation. And then teams go house to house to look for children who didn't come out to the fixed sites. And when they identify them, they are brought out of the house. So there is what we call directly observed vaccination. So that gives us confidence. So I think that a number of these measures of confidence building, direct observed, vaccination, we believe has substantially brought down the instances of fake finger marking. But this is something that the program is very, very concerned about and keeps a very, very close eye through its monitoring and validation strategies. Thank you.
Thanks so much. Moving on to another question from Obina Abirim. Are there areas of alignment of GPEI strategy going forward with Gavi 5.0 strategy to reach zero-dose children and missed communities, since most of the communities with polio variant cases are those with many zero-dose children or missed communities? I'll pass this to Aiden.
Super, thanks, Ali. And I think it's, again, a really good question. And I think that not only is there a very strong alignment, I think there's a really strong convergence between GPEI, Gavi, and what's called the IA 2030 agenda. Are essentially to support immunization going forward. And I think the key challenge for all the stakeholders is that with the major drop in immunization rates across the world during the pandemic, we're currently working through what is currently called the big catch-up. And really what we want to make sure is that for the communities in greatest need, we're not just bringing polio drops, we also bring as many other antigens and other services as we possibly can. And I think Hamid has already highlighted a number of examples in Afghanistan and Pakistan. More recently, we've seen examples, for instance, of polio directly supporting the administration of measles campaigns in Somalia at the end of last year and in Q1 of this year. And as we speak, there are kind of large-scale campaigns currently underway in northwestern Nigeria, looking to bring FIPV as well as a range of pluses to communities that are underserved. And I think the key message overall is that where we have those opportunities, where we have this alignment at our country and at subnational level to make sure we deliver the maximum range of services, then I think we're very much interested and are amenable to doing so. And I think it's more a question of not if, but how, and really making sure that we're as joined up as possible towards that end. So I would simply note that for GPEI, the zero-dose agenda is essentially what brought us into IA 2030 and Gavi 5.0, because we do believe it's absolutely essential on our journey towards finishing the job. So making sure that children everywhere, and particularly in those areas that are most underserved, reach or gain the maximum level of support is an absolute imperative. Back to you, Ali.
Thank you so much. And thank you for all of the questions and answers so far. We have time for one last question, and I want this to be a bit more of a round robin. What role do you see eradication and immunization advocates like the ones on this call can play in the fight to end polio? I'll start with Myra, and then we can go around the circle. Myra, go ahead.
Hello. Well, as a polio survivor, completely non-technical, but I have learned a lot this afternoon, by the way, and a lot I didn't understand, I heard, but very good. And I think I've met other polio survivors as part of the One Last Push campaign, and I think anything that we can do to talk about our experience, and also to I've contacted my MP several times about ongoing UK government support for polio eradication. And I think it's just a case of keeping up those kind of, that kind of advocacy as much as we can.
Thank you. Pass to Aidan, and then we can do Felicite, Hamid, and Ananda.
So thanks very much, Alia. I guess the point that I would make is that, across many countries of the world, I've yet to come across a mother or father who did not want the best for his or her child. And for me, I think, we've heard a little bit about the challenges of misinformation, disinformation, and rumors. The best response or antidote to those misinformation, disinformation, and rumors is the correct information delivered by trusted channels. You are those trusted channels. Please make sure you use your voice and are engaged in terms of making sure that our communities at risk, parents at risk, children at risk, are under no illusion that the best way to protect children is to make sure they're fully vaccinated against the range of diseases that are there. So I thank you for all that you've done and all that you're going to continue to do towards that end. Thank you.
Thank you. Felicite, go ahead.
Thank you so much. I think that's what is more important, that everybody has to play his part, and wherever you are in the community, with friends, you can play a big role to make it happen. Every little effort, it's really important in this last mind. And I think that there is at a global level support for that, and my organization as well. So I think that we can make it happen, and it can be a success. As Aidan said, that no matter, I've been everywhere in the continent, and what matters, what parents want for the children is the best. And those who are surviving from polio are saying that if my parents are vaccinated, me, I will not be there. So for me, it's very, very important to really play our part wherever we are. That's my message. Thank you.
Thank you. Hamid?
Yeah, thanks. First, I want to really thank Myra for joining us and being an advocate for the program. Your advocacy, your comments and your voice is extremely important for the program. So thank you for joining us today. Secondly, I think I just wanted to say that for each one of you, all of the people on this call and others, your voice is very, very important. Just to put it bluntly, Aidan and I get paid to do this work. Your voice as a representative of civil society is extremely important. There is a lot of misinformation out there, and social media has just made that worse. Please make sure that you get the right information. We are available. There are other resources available. And then speak to your communities, to your community leaders, to your government, to the donors that you interact with. Your voice matters a lot. Thank you for your support.
Thank you. And lastly, over to Ananda.
So I wanted to echo everything that has been said, and just wanted to add that, we all need to understand that being polio free is not polio risk free. And in all your communities, you have to communicate probably that message, the need to vaccinate, continuously vaccinate, and the essence of eradication, because it's only when we eradicate, polio-free becomes polio risk-free. I think that's why we need to keep up the momentum and connect with the parents, because as already noted, no one really wants their child to be paralyzed. The information is out there, we are all available, but it's really your voice, your connect with the local communities, that's going to make the difference. And thank you all for doing that.
Great. Thank you all so much. And thanks to everyone on the line for joining the briefing. Apologies we weren't able to answer all of your questions today. If you would still like to have yours answered, please feel free to email poliogcg@globalhealthstrategies.com and we'll do our best to get back to you with a response. We will follow up with a recording of today's event and an email with several easy ways that you can use your voice to help amplify the call to end polio now. And please don't hesitate to reach out if you have any further questions. Thank you again for your support. Thank you to our speakers, and have a great rest of your day, everyone.
Thank you. Bye.
Thank you.